Uh, Hey everyone, we'll just give a few more minutes in case a few other folks are joining. I know a lot of folks are on vacation right now. All right. Well, like I said, I think I know a lot of folks are on vacation right now, and it's a pretty busy time of year. But this is designed to be interactive. I think has a couple cases also, but I want to start because I don't know how long her cases will take, and I want to make sure for those of you that if we're are on now that we make sure that you get off in time to get to the rest of your afternoon obligations. Um, so the talk I have today, can everybody see my slides okay? You see my like the title slide?
Yes, and I think it's on the one where it allows you to also see notes.
You can see the note one. Let's see if I can fix that. Let me see. You roll on. Let's see. All right. Let me try to do that again. All right, how about now?
We can see your slide.
Awesome, thanks. I think a few more of you joined that I couldn't see either. But awesome. So here we go. So the first case that I have, it's a 32-year-old male, and he presented to me with a chief complaint of abnormal sleep behaviors, and he described acting out dreams since he was 28. He endorsed kicking, hitting, swearing during sleep with dream recall. And he recalled acting out a dream where he was a hockey goalie. Most often, the dreams really had a violent nature where he would be fighting. He hit his wife once, though he denied injuries to his wife from that episode or himself through the other dream enactment as well. Most vocalizations were swearing. The episodes typically occurred once and rarely twice per night. He did have a history of comorbid anxiety. He was treated with several antidepressants historically. Um, he, though, thought that the dream enactment behavior persisted when he was off antidepressants. The dream enactment behavior occurred 3 to 4 times per week, he estimated, when he was on SSRIs, and once per month when not on SSRIs. And when he came to me, he was taking Lexapro 20 milligrams in the morning and also Trazodone 50 milligrams at night. He denied any history of sleepwalking in the last 4 years or earlier in his life, including childhood. He denied awakening confused. He denied tremors, slowed movements, or any loss of smell. No history of PTSD or head injury. No history of sleepiness, cataplexy, hypnagogic, hypnopompic hallucinations, no sleep paralysis. He denied snoring, witness apneas, headaches, dry mouth, sore throats upon awakening. He had vivid dreams, but really denied nightmares outside of these violent dreams that he recalled that he would act out. And he came to me already with some tests that I put up here. I highlighted some things in bold that I looked at. So he had some workup already when he showed up to me 4 years after the presentation of his symptoms. And he'd had a sleep study in January of 2020. He was diagnosed with mild obstructive sleep apnea on that test. They noted some somniloquy. Now, I looked a little bit at the whatever fine print I could see on this study. It wasn't done here at the University of Michigan. And I won't tell you where it was at. It's not pertinent, but I know good folks are there. But he had no snoring that was noted by the technologist. So I thought that a little bit interesting, even though it said it's mild OSA. He really didn't have any symptoms of OSA, getting back to when he presented to me. Sleep efficiency was a little lower. There was no loss of REM atonia. They commented on that. They were doing it due to the dream enactment. They noted somniloquy was once noted in REM sleep. He was treated with auto CPAP after that, and eventually he had this other sleep study in January of 2022 to kind of reassess what was going on. Again, it was thought to be obstructive sleep apnea, predominantly obstructive hypopneas were seen. It was noted that there was no snoring, and snoring can be used to distinguish an obstructive from a central hypopnea. Um, there again, sleep efficiency was a little bit lower. EMG was noted to be normal. And then he had a titration after that where they did see some central events on the titration where ASV was initiated. They noted, interestingly, there was some sleep talking or a possible, they noted a confusion arousal that during non-REM sleep, they specifically stated atonia was preserved during REM sleep. And I commented on the sleep efficiency for the fellows that have read studies with me. Often I'll look at that closely if there are central respiratory events, because sometimes if somebody's not sleeping as deeply in the lab, that might be a reason where there might be enhanced physiologic central respiratory events. Sometimes it can be difficult to tell are the central respiratory events fragmenting the sleep or the other way around. So he had those tests. He did get an echocardiogram. That was all normal. I'll just go over that quickly. That was likely to decide on the ASV or to work up the possible central sleep apnea. He had an EEG. It mentioned occasional left frontal temporal delta slow waves. So those could signify possible focal pathology in that region. That's what that would mean. But that's somewhat of a non-specific finding. As folks get older, it can be normal to get some degree of temporal delta slow waves. More in seniors, but they did comment on that. One recorded spell of yelling occurred out of REM sleep without electrographic ictal correlates. So no seizure activity they found. And that left frontal temporal delta slow wave does not indicate seizure pathology. He did have the MRI after that. It was normal. So likely, my guess is that might have been an overcalled finding or a non-specific finding. We had EEGs to identify focal pathology. They're not perfect, and they predated what we now have with MRI. So those were the tests that he had. And he came to me with this diagnosis of REM sleep behavior disorder. And melatonin had been previously tried. It was ineffective. He had tried this ASV. He couldn't tolerate it. He before didn't really get any benefit of auto CPAP, and that's why they reinitiated treatment. Then he got ASV, really had troubles with ASV, tolerated it worse than auto CPAP. And then he was trying a mandibular advancement device more for obstructive sleep apnea, not clearly getting benefit out of that. And none of those things were really helping his dream enactment behavior, which he still mentioned it was happening, at least to his knowledge, 5 times per month with him currently on Lexapro. But really, he mentioned this to me. He said, since he learned that RBD could be associated with Parkinson's disease, he had been more anxious about his health for the last 4 years. He recently established care with a therapist who he'd been working with for the last 3 months. He was also following with psychiatry. Anxiety did predate his diagnosis of RBD, but depression and anxiety markedly worsened when it was thought that he might develop Parkinson's disease. So I wanted to quickly look over the diagnostic criteria for RBD just to remind ourselves of that. So this is all from the ICSD-3 TR. So repeated episodes of sleep-related vocalization or complex motor behavior. So we have to have all of these. Sleep behaviors are documented by video polysomnography to occur during REM sleep, or if we have a strong clinical history that they're presumed to be occurring during REM sleep, that can count too. We don't have to see the dream enactment on a sleep study. We need REM sleep without atonia to have a definitive diagnosis of RBD. He did not have that on the 3 studies. And the disturbance is not better explained by another current sleep disorder or mental disorder. And then if we read through the diagnostic criteria, there are the notes at the bottom. I won't go through all of these, but the last couple I just wanted to call your attention to just so that we're aware of just some of the current terminology. But it mentions on number 5 that there may be a patient who has a typical clinical history of RBD and might even exhibit RBD behavior on video polysomnography, but might not demonstrate sufficient REM sleep without atonia. Or maybe what it also mentions is you might have a patient, say, with Parkinson's disease. It's not easy to get them in the lab. You're really confident that they have RVD. So you could diagnose them with provisionally having RVD. And that's where I would put this. I would say he would fit the criteria. This patient would have provisional RVD. And then it also mentions this: RVD may be diagnosed in the presence of central nervous system acting medications. Certain antidepressant medications may contribute to REM sleep without atonia on polysomnography. Medication antidepressant-induced RVD may signal or unmask underlying isolated RVD. And then it mentions this: therefore, medication-induced RVD should be diagnosed as RVD. And this is a change. We haven't always done this. We used to have a diagnosis that was drug-induced RVD. But right now in the sleep field, we're saying medication-induced RVD should be diagnosed as RVD. But it also says this: pending future longitudinal studies. So, I don't think the jury's fully out on this, but for right now, we're classifying medication-induced RVD as RVD because often we've seen folks that might be on an antidepressant that are, especially if they're older, they end up having RVD, and then we still might see a synucleinopathy in them. And then these are the clinical subtypes. This is right out of the ICSD also. So isolated RVD, so drug-induced RVD should currently be classified as isolated RVD unless Parkinsonism or dementia are present. Then it would be secondary RVD. And secondary RVD would be if somebody has like an alpha-synucleinopathy. So that would be your Parkinson's disease, Lewy body dementia, multiple systems atrophy, pure autonomic failure, which is a rare alpha-synucleinopathy, narcolepsy type 1, autoimmune encephalopathies, brainstem lesions. That list is not all-encompassing of secondary RVD. Most cases of isolated RVD, especially in men that are over 50, and we'll come to this next, really likely represent a prodromal alpha-synucleinopathy. So most cases of isolated RVD, especially in men over 50, really represent a prodromal alpha-synuclein. And then this is another take-home point just to remember in pediatrics. I'm sure pediatric sleep physicians know this, but really most cases of RVD, I'd say almost all are likely secondary RVD. So we should really be looking for often narcolepsy, but other conditions when we see RVD in pediatrics. Other clinical subtypes: parasomnia overlap disorder. This is one where the definition or the term actually fits pretty well, but yeah, it's an overlap of parasomnia. So it's a patient who could have RVD and a disorder of arousal. That disorder of arousal, that's basically a synonym for non-REM parasomnias. Or sleep-related eating disorder. It mentions that, although I'd classify that as a non-REM parasomnia, but that's how the ICSD is written. Or rhythmic movement disorder. So especially in children, maybe rhythmic movement disorder with RVD could be what would be considered parasomnia overlap disorder. And then the third clinical subtype, much less common, status dissociatus. So that's where you would have lack of identifiable sleep stages, but with sleep and dream-related behaviors that resemble RVD. So uncommon, may be good to know for the boards, and you maybe sometime might see this more in an inpatient service because these things are pretty severe, but there's agrypnia excitata. That's Latin. It sounds like a Harry Potter spell, I think, but generalized motor overactivity, impaired ability to initiate and maintain sleep, loss of slow wave sleep, marked motor and autonomic activation. And you can see that syndrome with delirium tremens from alcohol withdrawal. So that's good to know about. Morvan syndrome, which is a rare life-threatening neurologic condition. It's basically with autoantibodies to voltage-gated potassium channels. The couple specific proteins that they found autoantibodies for are listed. That's good to know, and that involves the peripheral, central, and autonomic nervous system. So you can get dysautonomia with that. You can get neuromyotonia, often encephalopathy, and insomnia and RBD. And in fatal familial insomnia, also it can present with these sort of mixed sleep stages where you could get insomnia and you could get RBD. And then differential of RBD, I know most of you know this, but like sleepwalking, sleep terrors, these are things that I'd be thinking about as somebody we're presenting to be. Would they have OSA that might be leading to maybe a confusional arousal after respiratory events and REM sleep, sleep-related hypermotor epilepsy, rhythmic movement disorder, sleep-related psychogenic dissociative disorders, frightening hypnopompic hallucinations, and PTSD and trauma-associated sleep disorder. And then the course for isolated RBD, most men greater than 50 years or older with isolated RBD develop an alpha-synucleinopathy. So there's a large multi-center study. It showed about 73% conversion rate to Parkinsonism and or dementia often over a decade after an RBD presentation. And there's a higher conversion rate, like 80 to 90%, that was found in a smaller single center cohort with a larger follow-up. So I mean, those are really high and somewhat alarming if you have RBD and you're a male who's 50 or over. I mean, that's 90% chance or 70 to 90% chance you're going to get an alpha-synucleinopathy. There was some autopsy work in folks with RBD, and they found evidence of alpha-synucleinopathies being present at autopsy in 94% of patients. So that's why we've paid so much attention to RBD in the sleep medicine field, hoping to identify folks early that might get alpha-synucleinopathies and have a way to treat them or prevent them and learn things from research. Separate from RBD, the lifetime prevalence of Parkinson's disease is thought to be like 1 out of 1,000 or 1 out of 2,000. So, everybody's at risk of Parkinson's disease. Our risk goes up with age. That's the biggest risk factor for everyone. But certainly that number, 1 out of 1,000 to 1 out of 2,000, very different than 9 out of 10 or 7 out of 10 if somebody's like a male over 50 who has RBD. And then RBD exists in greater than 90% of multiple systems atrophy patients, 80% of Lewy body dementia patients, and about 60% of Parkinson's disease patients. And then prodromal RBD is a term that we're using now where we might have motor or vocal activity without definite dream enactment. This would be something we might see on a sleep study, maybe REM sleep without atonia. There might be maybe some foot movements. I've seen comments. I've read studies with fellows. We'll see some movements, but they're not overly complex. We're not confident it's dream enactment. Maybe there's not this history of dream enactment. So there's a thought, though, that you might have even just REM sleep without atonia might represent sort of a prodromal RBD, the beginnings of RBD that we might see earlier. So this is what I kind of where I wanted to go with this and to see what some of your thoughts are. But what should we tell patients with RBD? So this is from Eric St. Louis, who gave one of our Aldrich lectures before, who's done a lot of writing in this area. Prognostic counseling for patients with idiopathic isolated REM sleep behavior disorder. Should we tell them what's coming? And this is just the title of the article, and it says yes. We should tell them what's coming. But I want to go back to this. This was what the patient mentioned to me. Since he learned that RBD can be associated with Parkinson's disease, he has been more anxious about his health for the last 4 years. He's established care with a therapist. He's followed psychiatry. Anxiety predated his diagnosis of RBD, but it clearly, and specifically in talking to him, I mean, he was really worried about getting Parkinson's disease. This has been something that I think has absolutely worsened his anxiety and depression for the last 4 years. I mean, he had some anxiety before, but absolutely this has been a major concern for him. So in back to the patient counseling. So what are some of your thoughts on counseling? And I just to go over a couple things before I get your thoughts. One study showed that counseling occurred about 47% of the time for RBD patients. So we're not always doing that. And some thoughts that I want to get from all of you would be the following. Would and should your counseling of this patient differ from another patient with RBD? And then what factors would you use in some of your decisions about counseling? Um, a thing to consider is most patients are likely to learn about RBD, and that it's associated with neurodegenerative disorders on their own. There's going to be ample amounts of information on the internet. So if we don't give them some information, they're going to probably find out something from on their own. Um, and some things that are being balanced in some of these thoughts. There was actually a lot of literature in neurology about should or shouldn't we counsel somebody with RBD. So we don't see that with most conditions. We don't see that should we counsel somebody that they have cancer and what could happen. We don't see that often, but really it's existed here because often we've known about RBD and this risk, but there really isn't an actionable step that patient could take to prevent something. There's not anything else that they could do. They could see a neurologist frequently to see if they're developing Parkinson's disease, but there's not like a treatment to prevent it or to stop it or to help them. And really, it is kind of this autonomy versus non-maleficence. So a patient's right for self-determination, knowing their own health risks versus minimizing possible harm to patients. So with that, so would and should your counseling of this patient differ from another patient with idiopathic RBD? What does everybody think? Any thoughts, questions?
Hey, Dr. Garwood.
Hey, Josh.
Um, I actually sat in a talk at the sleep meeting, I think with Dr. Schutz, actually. Um, and we talked a lot about this. And the consensus kind of was that there isn't great consensus. They did like hand raising in the room, like what would people do? And it was pretty diverse. Um, but I think by the end of the talk, the the primary consensus was that the recommendation, if it is truly idiopathic, where we feel like they are meeting kind of the criteria and therefore may be at risk for an alpha-synucleinopathy, then they are due, like we should counsel them in that. But if it was related to medications or a secondary cause, that likely some other form other than a primary alpha-synucleinopathy is happening, it is reasonable to withhold some of that in that kind of setting until maybe a future time, or maybe it's just, hey, we're gonna keep following up with you and monitoring for symptoms of Parkinsonism and things of that nature, but have a little bit more reservation, especially in a patient who might be extremely anxious about things already, and you think that could be like throwing gasoline on the fire. Um, Hopefully I articulated that okay, but
Yeah, yeah, that's helpful. Yeah, like I think it may very like I think you're mentioning some really good points. Maybe somebody's at more risk of the harm than somebody else. If we could know who they were, that might be important. Um, and I mean, yeah, and are there some patients with RBD who are at a higher risk of this alpha-synucleinopathy, or are there some folks where we're pretty sure they have RBD, but not fully sure? Those things could absolutely play a role. So a couple thoughts they kind of follow what you mentioned, Josh. Um, this is also still right out of the ICSD. I thought this was really well written, but and summarizing as well. But it says isolated RBD is predominantly male disorder that usually emerges after age 50. Cases of RBD from early childhood up to age 88 have been reported. RBD emerging in adults before age 50 tends to have different demographics and associated features, including greater sex parity, increased rates of parasomnia overlap disorder, more comorbid narcolepsy, more antidepressant medication use, possibly autoimmune diseases. And then it mentions clinical presentation of RBD in younger adults can also differ from older adults. Less aggressive and violent behaviors. This patient did have the aggressive, violent behaviors. Um, and they're not sure. They mentioned maybe due to a greater female representation as a cause for the non-violent behaviors. I'm not so sure about that. and it mentions higher rates of narcolepsy, of course. But that does often have much more milder RVD behaviors. The movements are less complex with narcolepsy. There it could also occur early in the night. Don't forget, because your REM periods with narcolepsy are going to be in the beginning of the night, as opposed to like after a couple hours. So those are things to keep in mind. And then the male prevalence, maybe due to under detection in women. That's been questioned for a long time. Women do live longer than men. Men may be poor witnesses of women. So there could be a lot of reasons for that. It's unknown in this. It mentions this. It's unknown if specific RBD subgroups are at increased risk for development of Parkinsonism or dementia. And then it says these subgroups include patients younger than 50 with antidepressant medication use. That's him. Or underlying neuropsychiatric disorders such as PTSD. He didn't have that. But I think that, Josh, that's what you were mentioning. This group, these subgroups, may need different counseling, and it may need said quite differently than somebody who's age 50. And I wasn't there. I don't know how it was presented to him, and maybe I would have said things the same way. And then new antidepressants and other psychotropics, we really need to see how do they affect RVD and REM sleep atonia. We know the SSRIs, tricyclic antidepressants do. So that was the first case. I'll see if there are time for questions in the end, but I want to leave enough time for Fozzie, and this will go more quickly. And they're both on the same theme too. So the second case, 65-year-old female with a past medical history of hypertension, hyperlipidemia, stroke, and atrial flutter. This patient was prescribed donepezil, so Aricept, 10 milligrams, for multi-domain mild cognitive impairment of unknown etiology. So mild cognitive impairment. So what does that mean for a non-neurologist or for folks that need a recap? So that would be like some impairment in thinking that where somebody has more impairment than they should for their age and education. So that would be a mild cognitive impairment. If it's amnestic mild cognitive impairment, that would be a precursor for Alzheimer's disease. So that's one domain that's affecting memory. Mild cognitive impairment can also be multi-domain, or it can have other domains outside of just memory, like it could affect language or executive function. Again, when it's MCI, it's not really affecting activities. It's more something we would notice on tests, or the symptoms are subtle. They're not affecting activities of daily living. If it's multi-domain, that could be seen more with Lewy body dementia or vascular dementia, for example. But she was thought to maybe have mild cognitive impairment, maybe from a vascular etiology, but she got donepezil for that. Now, she mentioned that it led to vivid dreams where she acted them out or slapped in her sleep. She made noises, but her husband could not identify any specific words. Her husband estimated 4 to 5 episodes like these occurred. He woke her up a couple of times and asked what she was doing. She stated, "I don't know, I'm dreaming." After one of them, she once stated someone was after her and her husband observed her to be fighting. So with all those episodes, they were fighting like she wasn't confused. She knew what had happened. She reported her dream anatomy behavior really occurred after the donepezil was increased to 10 milligrams from 5 milligrams, with the dream anatomy behavior then completely going away when it was decreased back to 5 milligrams. And these symptoms have not occurred since discontinuation of the donepezil or prior to its initiation. She takes Lexapro in the morning for depression. She's been on that for 5 years, but has never had any symptoms of RBD on the Lexapro. Her husband notes intermittent loud snoring. She denied other symptoms of sleep disorder breathing. So what would you do next? Would you recommend any testing? All right, how about, would you recommend any testing? Anybody want to test for her? She does have snoring and a history of a stroke, hypertension, and atrial flutter.
mean, she's high risk for OSA, so a PSG, and then
For
you
sure.
could look and see if there's any REM without atonia.
Yeah, yeah, perfect. Um, and that's what we did. So she did get a sleep study, and this could be like name the attending physician. If everybody has the way they word things, that could be like if we could see if anybody can come up with who wrote these. But the first one showed uh, it did show obstructive sleep apnea. So her baseline study did. Um, there was loss of REM sleep atonia in the form of excessive transient muscle activity in the anterior tibialis EMG channels, no complex motor behaviors or vocalizations. Clinical correlation with dream enactment behavior was recommended in the setting of the patient's escitalopram, which is associated with REM sleep without atonia and RBD. And then she had a CPAP titration that looked to find an effective setting. Loss of REM sleep atonia occurred in the form of, again, excessive transient muscle activity, still no complex motor behaviors or vocalizations. And it was recommended to clinically correlate for dream enactment behavior. So REM sleep without atonia in this patient, unlike the other patient. And back to the other patient, I'm not sure what to make of the lack of REM sleep without atonia on his studies. I just feel like if we saw it here, we seem to find it almost in everybody here. So maybe their sensitivity might have been a little different. So I still am confident that that patient had RBD. Not confident that he'll get a synucleinopathy, but confident he had RBD. So donepezil and RBD. So what is your diagnosis for the patient's sleep-related behaviors? What is the mechanism of action of donepezil? A couple questions for you. How might that affect REM sleep? Is donepezil thought to precipitate RBD, help RBD, or have no effect on RBD? And do you think donepezil causes patients' oneric behavior, their dream enactment behavior? And how would you counsel this patient? So, and then we're almost done. But yeah, so what would be your diagnosis for the patient's sleep-related behaviors? And I'm going to help out too in the interest of time. But so yeah, I would say this one fits with RBD because they certainly fit the criteria of RBD. It doesn't say how long the episodes have to happen. Even a medication-induced RBD might show up. It might mean the patient's at risk to get an alpha-synucleinopathy. Maybe the medication's stopped and then later they have RBD without a medicine. So I would say the patients had RBD and their symptoms are in remission. What is the mechanism of action of donepezil? So I do want our fellows to answer this one because we just talked about this on Friday for some of them. But does anybody know how donepezil works? And everybody knows.
Acetylcholine inhibitor, acetylcholinesterase. It will yeah, increases acetylcholine. Or
yeah, perfect, Enrique. Yeah. Acetylcholinesterase inhibitor increases acetylcholine. So how might that affect REM sleep?
Increases it?
Perfect. Awesome, Manusa. And then here's now getting a little harder. Is the donepezil thought to precipitate RBD, help RBD, or have no effect on RBD, or I'm not sure. I'll take an I'm not sure. We'll come back to that. And then, do you think this donepezil causes patients' oneric behavior, dream enactment behavior? Gosh, it seems like it. It seems like it anyway.
in this case,
in this individual case, I guess, boy, it seems like it, unless there was some other precipitant. I mean, was her OSA worse those 3 months for some reason? And did that somehow cause something that looked like RBD? But it seems very clearly with that dose increase, and then the dose was decreased, they went away. How would you counsel this patient? We'll come back to this, but so acetylcholine. So we talked a little bit about this on Friday, but yeah, it's a REM on neurotransmitter. It works that we have these REM on and REM off neurons in the pontine tegmentum, so it's working on the precuneus and the sublateral dorsal REM on neurons, and it's basically sending signals And then you do have some of your monoamines from like your norepinephrine and serotonin. These are generally REM off, and that might be how SSRIs kind of affect the system and lead to like RBD. But yes, some more acetylcholine in REM sleep. And then acetylcholinesterase inhibitors decrease REM latency and increase REM density. There was a case series of 3 patients treated with donepezil at doses over 10 milligrams that did have a reduced frequency and intensity of RBD. Exelon was shown to reduce RBD. Another study though showed RBD patients with concomitant neurodegenerative disorders who were taking donepezil did not have significant changes in their RBD frequency or severity. So some conflicting studies and evidence. Acetylcholinesterase inhibitors were reported to induce RBD in a patient with Alzheimer's disease. So again, some of this conflicts, some different data. And if you read up to date, if it right below melatonin, then clonazepam comes acetylcholinesterase inhibitors. So good to know. And per up to date, it states that they could be considered for third-line treatment for RBD in patients who've failed melatonin and clonazepam, especially if they have non-amnestic cognitive impairment, which could be Lewy body disease early, dementia with Lewy bodies, or Parkinson's disease. And with Lewy body dementia, there are often these visual illusions where someone will see like an object and it will look like something else, and that they can really do better with acetylcholinesterase inhibitors. And then meds can induce RBD. These are the meds that are known. This is from Up to Date 2. It's a good table. Beta blockers, suvorexant's been found to induce RBD. Acetylcholinesterase inhibitors are also listed here. They're listed as a treatment and something that can induce RBD. We don't really know about the newer antidepressants. We need more research and withdrawal of some things. Alcohol, for sure, to keep that in mind. Withdrawal of things that suppress REM sleep, like Adderall. It's not listed here, but that absolutely could. I've not seen that, but it absolutely could. Somebody's taking a lot in cocaine. There are reports of that. And then last slide, it just follow up. So this patient did continue to follow up in the Department of Neurology. 18 months after a visit with me, there was some mild worsening of her memory. She was having some troubles with driving. So at that point, she fit the criteria for dementia because it was affecting her basically instrumental activities of daily living. Her driving is not specifically one of those, but it was more than just mild symptoms. They did not retry acetylcholinesterase inhibitors given her reaction. She did not want to. And there was no further dream enactment behavior. They did consider lecanemab, which is a anti-amyloid monoclonal antibody, which is now indicated for dementia. She's on anticoagulation, so it wasn't given. That there's some bleeding risk with those. They did recommend that she get sufficient and regular restful sleep in addition to other things that could help dementia. And she hasn't followed up after a sleep study. So we've got to look into that. So she has somehow been lost to follow-up. So that's a bit of an anticlimactic finish here. But her dream enactment behavior did not return. And yeah, her counseling, it might be a little nuanced given that she's a female and that it was drug-induced. Maybe I would nuance hers a little bit, but also she was having some memory troubles. But those are the couple cases I have. See if there are any quick questions, but I know Fazia's got a couple and I want to make sure that she has some time. All right, well, let me turn it over to Fazia, but thank you everyone. And let me stop sharing my slides here. Fazia, sorry to go over here.
No worries, Mark. So the quick question for the fellows. We have 15 minutes. We can do one case or we let you guys go on to your sleep studies. What would you prefer?
Depends on the case, Dr. Hassan.
Cases are never like, I'm going to ask about management. There's not going to be like a diagnostic dilemma. It's going to be more about like, what do you think and what kind of management are you going to do?
Is it palm related?
It's always palm related. Like it's never going to be neurology related for me. Like I am not
insomnia?
Yes, Anisha votes yes.
Thought it might be insomnia.
I know. It's like, oh, it's going to be seizures and insomnia for me. Like really? So,
Whatever we decide together.
so I'll leave it to you guys. We could probably wrap it up really quickly and go like 5 minutes over, but you all tell me what you would like to do.
We are voting here at the fellows room.
You're voting at the fellows room, then vote quickly and then let me know. You have like 20 seconds.
All right, PSG has won.
PSG is one.
Yep,
You want to go on and do sleep studies?
Correct.
Yep. All right. Sounds good, guys. And then we can just do the teaching as we go along. But let's just take 5 minutes to not review the case that I have because that is longer. But is Enrique on?
Yep.
Yes.
Okay. So actually, let's do a case, like just 5 minutes. Let's do a sleep study that Enrique and I reviewed yesterday. That was a titration study in an adult, right? Enrique, do you remember like what was the CO2? It was
70 in resting.
70 in resting, right? And the
Yeah.
baseline oxygen saturation on 3.5 liters was how much?
So it started with 50s, and then they had to add 1 liter to all the way to 3.5.
Okay. So, okay. And everybody can unmute, and if you can do on camera, great. What would you diagnose this person as? Like, what would be the diagnosis?
I know. Do you want me to answer or
No, you don't answer because we already talked about it.
Can we put the numbers like in the chat or something?
Just say it out loud, Josh. None of you guys are shy, and neither am I. Just tell me what you think is a diagnosis.
I think we're visual learners. Hold on, what was the numbers?
Okay, I'm gonna put the numbers in the chat, okay? Enrique, tell me if I'm wrong. So 55% off oxygen, and it was what, 70 CO2? Enrique, is that what it was?
Yeah, 70 resting TCO2 and oxygen 50.
Okay. All right, that's what it was.
Resting.
Baseline.
No, an adult.
Adult.
For the diagnosis?
Yeah. So what is your diagnosis?
I would say
Hypoventilation.
acute. Oh,
Okay. Okay. Besides that, what is the other diagnosis that you'll put? You can add on there.
is it like acute
Hypoventilation.
hypoxic hypercapnic respiratory failure?
Acute or chronic, whatever. You can put like chronic respiratory failure because I'm sure nobody's going to walk in the sleep lab with acute respiratory failure. It's a chronic respiratory failure, right?
Yes.
Okay.
Big
So
time.
now,
Tell me why, Fozzie, you say respiratory failure. Like,
so anytime you have a CO2 above 65, you automatically consider it chronic respiratory failure.
It has to be, so by definition, respiratory failure if the CO2 is over 65.
65. So 65 is very easily like respiratory failure, without any doubt. Anybody is going to buy that.
Exactly. Yep.
All right. Now, if you have to start therapy, what should you start?
Bi-level, right? I think at least to get going with something with a pretty broad pressure support range, whatever can maximize the patient's tidal volume if they can accept that data. But max, yeah.
So what pressure support would you choose?
I mean, I actually got called in the middle of the night with this patient, so I remember, and I was like, they were like, oh, this is just a baseline. I'm like, I think this patient needs to be split urgently regardless. And the EPAP can be really bare minimum because I think this patient didn't have any sleep apnea, so that's not the issue. The upper airway obstruction isn't. So I think a very high IPAP or a driving pressure is very important in this patient. So somewhere above even, 10. Upwards of 20, 25 to keep the EPAP really low.
Oh, dang.
That's kind of something that I would do.
Right. Okay.
Yeah.
Okay. So this is exactly what we're talking about, right? So this patient got started on CPAP. Like, people never do CPAP. Like this is not even like up for discussion. If you've got chronic respiratory failure, like CPAP should not even be insurance. Don't worry about insurance. Like nobody's going to fault you for doing that. And then a pressure support was maintained between 4 and 6. Like respiratory failure should never be between 4 and 6. At the very bare minimum, it should be 10 centimeters of water. And even 15, 20 centimeters of water is perfectly okay for respiratory failure. Like that is what high intensity BiPAP is. 15 to 20 centimeters of water is fine. And then somebody had the idea to start a backup rate of 10. Like if a pressure support of 6 is not working and you add a backup rate, when would you add a backup rate of 10 in this? Or would you add a backup rate of 10?
No, I wouldn't, unless the patient was having central sleep apnea.
Right. So like these people, so nobody's going to approve of a backup rate unless until you've tried a very high pressure support, right? And then you have central. So in these patients, it's very easy to go up on the BiPAP. And then if they don't tolerate BiPAP for any reason, like pressure support of 15, 20, you can then argue of a need to do a backup rate and they start having centrals, but there is no problem whatsoever starting at pressure support of 10 centimeters of water. Like that's, you can actually just start at that, like BiPAP there and then just move on. Because I think that's where the sleep world doesn't meet the pulmonary world. Like we all think CPAP and it's OSA. It's not. It's like you're treating respiratory failure, start there, start at a pressure support at least 10, make it higher, and then move on.
I think, I mean, because and even that's kind of what I did tell them about starting NIV from the get-go with very high pressure supports. I'm not sure what happened in the middle with the split and what happened. And I think they were really looking for a protocol. And there isn't, apparently they had to pull up like a protocol from PEDS for just hypovent without sleep apnea. And that's kind of where things got messy or murky. I'm not sure, but they were really pulling it up. I'm sure there is one, but I think on that night, it was hard to, they really wanted to follow protocol. I think they really need a set of rules.
So I think there's where, our sleep lab protocols are for OSA, right?
Right.
But when you're calling a physician of the night, then the physician, what they say goes, right?
Correct. And that's actually when they started the study, the patient was already hypercapnic. And I was like, okay, then see if we can at least get AHI of 5. But if we don't, in 2 hours, start NIV with BiPAP with a higher pressure support range. And I don't know what happened. I really don't. I didn't follow through after they called me and when I told them, but I don't know. Anyway.
So like protocols is what they have for them to follow. And then once they call a physician, then it's like, you've already called a physician, and then what you say is goes, right?
I am not, at least in our experience as fellows, it becomes, there is definitely a lapse in communication that ends up happening. So,
okay, so maybe we should talk to Neeraj, because there is, if there isn't for like these kind of situations,
Ozzy, I think you froze up.
I mean, while we're waiting, I don't want to be this person, and we can relay this to Dr. Hassan, but I literally got a text message from one of the techs telling me that staff are on call because they don't believe a lot of what fellows tell us, and they don't want to necessarily listen. And they thought that I was like lying and trying to harm a patient. So they made me wake a staff up in the middle of the night who told them almost the exact same thing that I did.
Oh my God.
Like, it usually isn't that bad, but we have had multiple times where the sleep techs will be like, well, we're not really sure we agree.
Sorry, yeah, like my internet connection is horrible right now. Okay. Can you guys hear me?
Yeah, we can hear you.
Okay. So if we need to have like a lab thing, then we can talk to Neeraj about it. But I guess once they call you and say that this is what you want to do, then I think that what the physician says should go. If it's not in the protocol.
No, but I really do wish that's what the case has. And personally, maybe 1 or 2 times it has gone through based on my communication, but at times I think they say yes at that time and that they were going to do it, but in the morning when we end up seeing the titration, no, I don't think it's anyone's fault particularly, but they really heavily rely on some protocol. And I think for their own, I think their comfort at night, they rely on something. So maybe for that purpose, even though we can give phone orders, they tend to fall back on something already preset is what I'm understanding from this entire year.
I agree with Anisha. Especially when it comes to pediatrics.
I've heard that in the past, but a little bit more this year from all of you. So I think if it will definitely, I'll watch for that. And I think some of the other attendings will, if we hear that feedback from fellows, we need to iron that out if there's like, conversations or if there's some discord, fellow tech interactions.
Sounds good. All right. So, but just remember that that high intensity BiPAP, I know most people are very reluctant to use it, but it is known as a therapy option. And a lot of us, even younger kids, go to like 15, 18, 20 centimeters of water pretty easily if it's tolerated. So it's out there, use it. Don't be shy about it.
Thank
Okay.
you.
All right, go forth and conquer sleep studies, people.
Thank you so
Thank
much.
you.
Thanks, everybody.
Thank you.
All right.
Thank you both.
Bye.
Bye.
I still remember to promote most. Have a good, Jen.